Everyone. I think I will be seated here so that you can hear me. I was very low. So I'm very happy for the research talk scheme. I'm going to tell you a few words about me, about my research background. So my initial studies are in law. I graduated in 2008 with a bachelor degree from the Democritus University of Thrace, and then I proceeded with my first master's in sociology, philosophy, and history of law, and I specialized in jurisprudence and legal philosophy in Thessaloniki at the Aristotle University of Thessaloniki, and then I proceeded with a second master's degree at the University College London, where I also took a major in jurisprudence and legal theory. And then I concluded my trajectory with my PhD at the Freie Universität Berlin in Germany, where I was part of an interdisciplinary project on law, politics, and ethics. But my main specialization, again, was in ethics and legal philosophy. Alongside that, I also had interdisciplinary research. I was involved in research initiatives, so I undertook some pre-doctoral and doctoral fellowships. So in 2015, while I was preparing my doctoral proposal, I was part of the annual Visiting Research Fellowship scheme at the University of Lucerne and the Lucerna Juris Institute, which specializes again in interdisciplinary legal discourse. So it's about law, politics, and ethics. Then in 2016, right after, I did an annual Van Kalker's fellowship at the Swiss Institute of Comparative Law in Lausanne. And during my doctoral studies, I was also part of the BLab Center at the University of Milano, which unfortunately I was not able to complete due to COVID restrictions, which, as you remember, Milan was one of the cities that was heavily impacted by COVID-19. During that time, also, I found very fruitful that I did several research training. I took part in several research training programs. So in 2000, these are some of them that were related with my primary field of studies. So in 2013, I was part of the Critical Theory Summer School at the Birkbeck Law School. And then I also did the Venice Academy of Human Rights, where we talked about the rule of law and human rights issues in ethics and the public discourse. I also did a training at the European University Institute, and one of the most interesting trainings I have had was the one at the Institute for Global Law and Policy at the Harvard Law School, which was in collaboration with the Thailand Institute of Justice. And there we were paired with health professionals, public policy makers. It was a very mixed group of practitioners and academics. And one of the most recent and also very helpful for me, one of the most recent research trainings I had was at the New School for Social Research, and it was focused primarily on feminist research discourse and how we can use post-feminist techniques in addressing complex issues around social sciences and the humanities. So my doctoral research was on the austerity measures and how this impacted social rights, especially in the European South. And by that, I primarily gave focus on Greece as a case study alongside Portugal and Italy and Spain. And during my doctoral studies, I specifically studied issues around the concept of individuality, the criticism around individuality as a human condition and individualism as a liberal governance project. And this led me to my current project, which evolved during my postdoc studies. And it involves questions around the so-called ontology discourse and process ontology in this regard. So in my current project, I look into how ontology matters for bioethics, and by that I highlight the aspect of how, because normally the ontology discourse has to do with questions of why and what. So in my research, which I do alongside other colleagues, we specifically focus on the processes. And by that, we take life as a process, and we are trying to rethink, as we say, and unlearn the assumptions by which we were taught, and the assumptions that have to do with what we mean by ethics and ontology in medicine. So my research specifically focuses on the so-called process-oriented ontology, which involves issues of ethics of care and the vulnerability theory discourse. And this challenges the other, let's say, the other part of this debate, which is the so-called object-oriented ontology. And I will go a bit deeper into that in the slides as we follow. But to conclude, like my research project also falls within the broader process philosophy and philosophies of movement and becoming, as we call them. So it is all about this idea of shifting from the so-called human condition and the idea of being as such to existence and to the idea of becoming in ethics and in clinical ethics by extension. So the core philosophical shift that we are trying to do in my research group is also what we call the shift from substance metaphysics and essentialism to processes as such, and to what that entails in terms of ontology, ethics, and the life of medicine. So in broad brushstrokes, and to give that in a rather simplistic way, what we mean by substance metaphysics is that the metaphysical discourse treats persons as bounded selves and as already pre-individuated entities, and the focus is placed here on the idea of entity and condition. So in substance metaphysics, it is assumed that we have fixed identities that are ascribed to us at birth, and that there are discrete causal links at all times. So these causal links means essentially what we call social determinism. On the other hand, in process-oriented ontology and process philosophy, we challenge all of the above assumptions, and we understand life as a dynamic, metastable, relational, and continuously unfolding process. So in this particular concept, we emphasize on the process of individuation as such. So it is not about us being pre-individuated, but it is about us individuating as long as throughout our lives. So it is all about becoming, and we place focus on the notions of interdependence, mutual aid, solidarity, and we highlight practical angles of medicine in this regard by placing the focus on that medicine already operates as a de facto process science. And in this research project, I take ethics and ontology as a unified field, and that is because if we do understand ethics as the scientific field that replies to the question of who we are, so then ethics is identical in a sense with ontology. And by ontology, we mean here the study of the nature of existing, right? It is not ontology of knowledge. It is not about whether what we know exists, or as we call it, it is not about the validity of the conditions of knowledge or the conditions of the validity. So if we, in this project that I'm working on, understanding ethics and ontology as one unified field challenges the very idea of essentialism and normativity and what we mean about normativity in the identity politics discourse. And by looking into process-oriented ontology, ethics is justified in concepts that have been quite neglected in the history of political thought and of human thought, especially in the Eurocentric Western tradition. And these concepts are relationality, vulnerability, and interdependence. So process-oriented ontology challenges the very idea of abstraction, idealism, individuality, and individualism as a governance project. And by that, it brings forward implications for bioethics by extensions, in the sense that it moves bioethics beyond the binary of self-agency and structural determinism, and it moves the bioethics discourse beyond the choice-based autonomy. So a process-oriented ontological discourse that we follow supports what we call relational autonomy, shared and distributed responsibility, as opposed to individual responsibility, context-specific ethical reasoning, and by extension, it aligns with care ethics, vulnerability theory discourse, and public and population health ethics. So, of course, process epistemology and its relevance has been highlighted during the last years, especially in biology. And John Dupré, who I also collaborate with, he has taken a huge ERC grant 10 years back when he envisioned the idea of process philosophy and processual and a processual understanding of biology in this regard. So what they do at the Ioannis Center for the Study of Life Sciences is that they look into process epistemology and how we can learn better by focusing on the processes and not the outcomes. So this is a research that they published right after COVID, where they were claiming how process epistemology, specifically in the COVID-19 era, in the post-COVID-19 era, could provide for fruitful reflections. And by that, they highlighted that life sciences already model developmental processes, epigenetics, and ideas of plasticity. And process ontology also provides, in this particular example that they used in the post-COVID-19 era, it provides for a coherent philosophical grounding. And by that, they talk about philosophy of biology, political philosophy, and the humanities and social and life sciences broadly defined. So process epistemology in this particular context helps to bridge biological dynamism and the so-called idea of a radical philosophy of flux, which goes back to the work of Bertalanffy and to our own ancient Greek thinkers, to the work of Heraclitus. So by looking at the Heraclitean philosophy of the radical flux, they avoid the so-called, let's say, big debate again between reductionism and complexity. And by that, they say that if we adhere to a process ontological scheme, we can avoid reductionism without abandoning scientific realism. So the implications for critical practice as process can also involve notions of clinical care being a trajectory, or as we call it, no longer an ontology, but an ontostory or an ontonarrative. So it also challenges the very notion of life happening as an event, or life being several different moments in life, like throughout our individuation. So it is all about ongoing relationships and the preservation of those relationships, and not about single decisions. And process-based ethics in this particular framework highlights the idea of consent as being iterative and understands diagnosis as provisional and evolving, which is quite radical in medical ethics. And in this particular context, it treats vulnerability as situational and exceptional by locating the discourse in the so-called lived experience and situated knowledge by Donna Haraway, Jane Bennett, and other post-feminist thinkers. It is especially relevant also in cases of chronic illness, mental health, end-of-life care, and precision in digital medicine. And also process thinking and process epistemology has implication in the law, governance, and responsibility discourse. And by that, substance metaphysics, it challenges what substance metaphysics underpins, and that is that liability models have to be only individualized and responsibility has to be only event-based. So process ontology enables, on the other hand, distributed and shared responsibility, institutional, structural, and systemic accountability, and more just models of health governance and allocation and allocation of resources. So a potential impact that it can have is located within algorithmic medicine, resource allocation as previously mentioned, and health accumulated structural inequalities. So to sum it up, do I have 5 more minutes or so? Yes? So to talk a bit about the international collaborations that I am working on at the moment, one of them is the Law and Process research group that we have developed with several different scholars at the United Kingdom, and we have a workshop coming up in February. We have held our first workshop was last year at Kent. So it is a collaboration between the University of Kent, Warwick, Westminster, and Loughborough. And we also moderated an international conference at the University of Exeter and the Ioannis Center this summer. Also, another collaboration that I'm particularly happy and proud of is with Dr. Panayotannakou at the University of Cyprus in Nicosia, and she also teaches medical ethics and medical law. And Dr. Panayotannakou has put forward a cost proposal for genome consent at the European Network on Ethical Consent, and we are awaiting the results. So it is also an international collaboration among many different health practitioners and academics and theoreticians in also European South universities. Aside that, I'm also involved in different networks and labs, and one of them is the Rio de Janeiro PUC-Rio-based speculative legal theory network, where we especially deal with the so-called speculative humanities and speculative social sciences. So this challenges the very idea, as I mentioned earlier, of idealism and abstraction in social sciences. And at the Speculative Legal Theory Network, we look specifically at context-specific cases and issues of lived experience and situated knowledges. And one of my most recent collaborations is also with the Westminster Law and Theory Lab, where I also I did a lecture, an invited lecture back in December, and I'm working with the research fellows there in addressing questions on theory of individuation and how this is implicated within the life and social sciences. And prior to that, I also had some grants, and I continue to have some very significant to me collaborations with the Nomo Center for International Research on Law, Culture and Power at the Jagiellonian University in Krakow, which is based in Poland, and the academic network of the European Social Charter and of Social Rights, which is based in Strasbourg. And there we have dealt profusely with questions about resource allocation in public hospitals, what happened during COVID and after COVID. So we deal specifically with the impact of structural inequalities in the protection of social rights. And here are some of my most recent publications. If you would like to read more about my research, three of them are pending. No, two of them. The other one I didn't include it yet. So my most recent ones are in relational vulnerability, relational justice, and vulnerability as an anti-epistemic process, and about law as process in a philosophical sense, which are going to be published by the Maren Martin publishing house in Paris, and the other one by the Sifting Nature's collective publication, which is edited by the Institute of Cultural Inquiry in Berlin. And to sum it up, why am I doing this research, and why do I think that process epistemology can be significant and why it matters for medical education? That is because we do tend to think that this can have an actual impact, a positive impact on the future practice of clinicians. And by that, we tend to focus on the recognition of the clinical practice and its ethical complexity. And by that, we tend to focus on the complexity of this as being structural and not only exceptional. And also, we do tend to focus on understanding patients as not bounded and pre-individuated entities, but as relational beings. And we challenge the very notion of our nature as being isolated and individualized. So we focus on the human nature as being a relational nature. This can potentially have within our university impact on the so-called One Health mission program that the UNIC Athens and UNIC Cyprus are involved in. And this talks about the shared responsibility and collaboration between multiple disciplines, not only medicine, but life sciences, broadly defined, biology, and also the idea of moving beyond anthropocentrism and talking about the post-humanism era. So One Health mission is focused on the so-called post-humanism era. And the last part is the ethical reflexivity. So process epistemology can have an impact on interdisciplinary thinking. And by that, I mean that a few years ago, as a legal scholar, I wouldn't be sitting, as I'm sitting here now, talking to scholars that have primarily health, a background that's primarily focused on health sciences. So this ethical reflexivity focuses on the idea that clinical judgment has to be always human and inclusive. And as we have already said in our lectures, we might depersonalize the patient, but we never dehumanize the patient. Thank you very much for your... Okay. Παρουσιάσει. Okay.
Okay. Okay. As you already know, my name is Dr. Eleni-Kyriaki Vetsika, and I'm assistant professor in biochemistry. So I'm going to give you like a very free background, background of my educational background, which you can see I hold a BSc in biochemistry and applied molecular biology, and then MPhil in biomolecular science from UMIS, which is in Manchester in UK. Where they're specialized on brain stem cells. That's where I had my thesis, both for my BSc and my MPhil. And follow that, I hold a PhD in pharmacology from Queen Mary and St. Bart's in London, UK. And where there my thesis was in neuroimmunology, and exactly I was trying to see the interaction of the immune system with the nervous system. So I had at that time, I started to say that the systems, they don't work individually. So a better understanding of how the different systems in our organisms collaborate and they work together, if we can get a better understanding of how they work, and they have been influenced between them. After my degrees, then I started my scientific research pathway, which started in Imperial, and I moved to the university, medical school at University of Crete, where there I started to use again the immunology and how the immunology interact by that time in cancer. So how the immune systems can influence the progression of the tumor, and if we can work and we can look closely at how the immune system can attack the tumor cells, then we will be able to eliminate. As we can see now, it's a big thing. It's like immunotherapy. It's a big way of trying to treatment when we're moving from the surgical resection and chemotherapy. And the latest one was in 2019. I was the head of a single-cell proteomics, which is a new center that was being made in the medical school, National Kapodistrial University of Athens at medical school. And there I was trying to use single-cell techniques in order to try to advance the research, especially in cancer and in inflammatory diseases. So by gaining from all this background during my education and then of my postdoctoral research, I try to see the big picture and the big clinical problem. And when I was looking at these different diseases, I found that why do patients with the same diagnosis, they respond differently? So we have the same we have patients that have exactly the same disease, but when we treat them, we have different outcomes. And not only that, we see that if we take the patients and we give them exactly the same therapy, then there is a problem. Some of them, they respond to that treatment, and some of them, they do not respond. And why is that? What is the thing that makes the patients to respond to the specific treatments? What differentiates these patients? And other things, like nowadays, most of the times when we want to do diagnostics, we take, say, for cancer patients, we take tissues, the cancerous ones, and we try to see what is wrong. And actually, when we do that, it's like a static snapshot at that specific time. So we do not look at the disease during the treatment. We do not do monitoring, because sometimes, most of the times, it's not easy to do biopsies. We cannot keep taking, especially cancer patients, we cannot keep taking a biopsy, say, from lung cancer. You cannot open the patient, they keep taking to see if they do respond to specific drugs. And several of the examples, and when I say examples, I said specific diseases that I'm working on is with cancer and with autoimmune diseases. And I was trying to put in these diseases the involvement of the immune system. And by saying that, down here, you see nowadays that a big thing is that actually our immune system actually is monitoring the cancer cells that they're circulating in our system. And that's what we call immunosurveillance, cancer immunosurveillance. And why is that? Is that when you have the immune cells, it's similar, the one that try to attack the pathogens. When we have an infection or we have something, say with COVID, with all the disease, the flu, it's the immune system that actually is going to be activated, and it will try to eliminate the disease cells. So if we say that the cancer cells, that are disease cells, so again, you have the immune system, the immune cells, T cells, that actually what they do, they screening, they go around your organism and then trying to see, and, sorry, I'll move that, and say that, so we start here, you have all these cancer cells, they do express things on top of their cells. They present that to the T cells, so that means that the T cells, they will become activated against that specific cancer antigens. So that means that if you have that, then you have activated cells that they circulate, and then they go again to the site of the infection, inflammation, cancer tissue, and they try to kill these cancer cells. They recognize the protein that have been made from. So it's exactly the same thing. So nowadays, they use the immune system to boost the immune system to eliminate cells, or they have found all these different molecules that they use as biomarkers. Do you know what is a biomarker is? Biomarker is like a molecule or that actually you can use that to see if, for prognosis, to say if it's something it's going for a disease. If I have this protein, so that means I have that disease. So that's a biomarker. But as a biomarker, you cannot only use it to say if there's something wrong, if I have a disease, but I can follow it if I give a drug to see what is happening to the disease. Okay, that's a biomarker. And another big thing that we do have, and as I say, that we have patients that, okay, so they have that disease, so we give the same drug. So we say it's like our gloves or like clothes, that is one size cloth, one size drug. So we have to say with all the results that we have that one size does not fit all. So that means that actually what we want to do, we have moved to that personalized medicine, and by saying that, it's trying to see biomarkers, molecules, our DNA, genes, that actually can take that out and can discriminate what drug we are going to use in order for the patients to benefit from that. So that doesn't mean that if I have me or Eleni exactly the same thing, if they give us the same drug, we're going to have the same thing. We have to be screened in order to identify what makes a difference. And by saying that, you have to have in mind that our human genome is identical to all of us in 99.9%. But if you look, the person that is sitting next to you, are you the same? No. So it's like that 0.1% that actually makes us unique. And that 0.1 that probably is responsible that we're not responding to the same thing when we're taking the same drugs. Okay. So what we need to find, what it will be the best thing for us to proceed, is that we need to find dynamic, personalized biomarkers in order to be able to attack the disease that we have. So my current research, as I said, I'm looking for patients with specific diseases. So it's like translational research. And actually, I'm trying to put immunology into a clinical applications by using liquid biopsy. And by saying liquid biopsy, it's the one that I'm trying to use fluids from our body, like blood, saliva, tears, that actually would be able to identify biomarkers and not using the actual tissue that's been using all of these years. And because liquid biopsies are non-invasive diagnostic tool, think about that. If I have, as I said, cancer, if I find the biomarker in the blood, how easy to draw blood compared to open and operate and take tissue from the cancerous area. Yeah. And the reason is just to discover prognostic and predictive biomarkers, both for cancer and autoimmune diseases. And I'm doing that by looking at single cell level. And I will explain that why I'm looking at single cell level. The problem here so far is that all of these times we had the bulk analysis. And actually, if you say you have millions of cells and you try to say why is wrong, if you put them all together, okay, you can see something that is similar to people, to the patients. But sometimes you have individual rare cells that actually the one that actually is causing. And an aspect nowadays that everybody's saying is that the heterogeneity, you're going to hear that a lot. Now it's something, a big thing, that actually we should not look at a whole lot, the bulk analysis, but probably you have to go and move on to single cell analysis. Because say, and again, I'm going to give us an example for cancer. Nowadays, they try to do that as a single cell because sometimes they say, okay, I have cancer and I've been treated. They say, okay, eliminate. But sometimes, and when you try the drugs or you do chemotherapy or immunotherapy, some of the clones, like one cell, probably is different from all the others. And that one cell may not be dead, may not be irradiated when I use that disease. So that specific one, that one clone, that one cell, if it's there free and alive, probably it's going to be proliferating a lot, and that's going to cause what you have after that. Yes? So the best thing is to do single cell analysis. So by saying that, I mean to say what kind of cell is that? It's like, and then not even to say, okay, I have that kind of cell that is different to the one next to me, but I have to find the function of that specific cell. So I have to find the functional state. And then, okay, I see what kind of things that are being released. And then I have to look at the signaling pathway. So if I click that, what the signaling pathways are going to follow after, say, that I activate one of the receptor for a cytokine or whatever of the MAP kinase, which is a big thing. You have lots of drugs against the MAP kinase signaling pathways in order to stop the proliferation of the cells. And another big thing is like to see what cell is interacting with other cells. So what information is passing by. And the next thing, as I said to you, is liquid biopsy. So actually it's medicine without the scalpel because it's minimal invasive. You can take it as many times as you want, and it reflects real time. Actually, I can take at various times at a specific time that I want to see. Samples, peripheral blood, saliva, smears, and down here I'm working a lot with small extracellular vesicles. I have no idea if I've heard that before, but that small extracellular vesicles are small vesicles that actually they've been released from all of our cells. And what is unique to that is that they're extremely small. They're smaller than the virus. It's about like 60 to 100 nanometers, extremely small. They can pass the blood-brain barrier. And actually, these small vesicles can be found in all of our fluids in our body. And that's the clue, that's the best thing, can transfer all the information from the cell that is coming from. So that means that all cells, they release those. So this, they have all the information, it's like a mini-me of the cells that are coming from. Yes? So that, but the good things that they can go everywhere and they can spread the information everywhere. It's not that they have been made and they have the information of the cells that are coming from. They can be act as cells and transfer all the information. So that's a really good thing to show us. So the technologies that I'm using for my research is like all state of the art. It's like all the new technologies that have come now. It's like mass cytometry, single cell transcriptomics, only spatial. And when I say spatial, it's like a transcriptomics and proteomics. Actually, you can see, okay, I'm talking about liquid, but you have to always have next to it at some point the spatial, the tissue. So to say, okay, I found this in the liquid biopsy, can I use it? Is it in the tissue? So that's why you have to have spatial, because there actually you will be able to see which cells interact with what and the close proximity of the cells. So to see the bigger picture, the network of the cells that are making up, and the single cell mass spectrometry. So the disease that I'm looking at is in cancer. It's the cutaneous T-cell lymphomas and pediatric and adult brain tumors, gliomas. And then I'm looking at autoimmune and chronic inflammatory diseases, such as rheumatoid arthritis, spondyloarthritis, psoriatic arthritis. And all of these diseases, I'm looking for the immune dysregulation as a common mechanism of these diseases. And why I'm looking at that, what is the clinical impact of all of my research, is if we can have an early diagnosis, if we're looking at specific biomarkers, for a better patient stratification. So that means that what kind of drug I'm going to give to what patient. I can monitor the therapy, and as I said, if I use liquid biopsy, so that means I can retake, so I can monitor the disease according to the therapy that I'm using, giving to the patients, to see if I can predict the relapse of the therapy. And finally, if I'm going to be able to find new therapeutic target drugs in order to advance the personalized medicine. So the current research projects, as I said, is small extracellular vesicles and peripheral blood as a potential source for liquid biopsy in pediatric adult brain tumors and chronic inflammatory diseases. The second one is identification of new prognostic and predictive biomarkers by using liquid biopsies to complement tissue-based biopsies. The third one is identify liquid biopsy-based immune signatures, so we can use them for disease monitoring in inflammatory arthritis and pediatric brain tumors. Sorry. To characterize disease heterogeneity at single cell level by identifying unique proteomic signatures in order to associate with different disease subtypes. So to say this is the subtype of the disease, so that means this is the signature, so I can define what is wrong and what the clinical outcome are continued. And the last one, I'm trying to decipher the immune cell landscape in tumor microenvironment by looking at the immune cell composition, functional states, the signaling pathways, and the interaction of the different cells within the tumors. And if we can identify that, and if we can map all these different molecules, that will lead to novel therapeutic targets and immune modulation strategy in order to enhance cancer immunotherapy. My collaborators, so all of these projects, they're running with these people from these different departments. It's from the Department of Biological Chemistry, National Capodistria, and University of Athens with Professor Perry and Dr. Adamopoulos. For the liquid biopsy for the tears and saliva is with the Medical School University of Manchester in UK. For the cutaneous T-cell lymphoma is with Professor Pavlidou, and the single cell mass spectrometry, they're running with collaboration with Dr. Martina Semiotakis from the Alexander Fleming Institute. Now, when it's coming to the inflammatory diseases, my collaborator is Professor Spikakis and Associate Professor Fragoulis with the Co-General Hospital in the National Capodistria University. So that comes to you if you want to join my research journey and if you do a research with me. These are the things that you can be involved. Is you can actually participate in laboratory experiments if you do so, if you wish to do so, or you can help to do analysis of all the things that we have taken so far, or we can be co-authors in publications such as reviews or the research papers. And this is a full, and these are links for full publication list in order for, if you're interested in, to go through and see what is my research. And thank you very much for your attention.
Να περάσει, ναι. Είναι λιγότερες λίθες, είναι εκπροσώματα. Θέλετε να κάνετε την ερώτηση εδώ και να την αφήνω και οι άλλοι. So, okay. All the questions at the end. Thank you, Professor Kararigas. So I am Dr. Eleni-Kyriaki. You already know me because we have done a lot of cellular biology together, but today I'm going to talk to you about my main discipline, which is histology. What is histology? It is the study of the tissue, but it is a relatively new discipline in medicine, relatively new. It is more than 400 years old, but taking into account that medicine is more than 1,000 years old, so it is relatively new. And why it's new? Because it needed instruments. And why we needed instruments? Because histology was formed by the curiosity of people to see the invisible. What was not visible with our eye, we needed special instruments to be able to visualize. This is Professor Dr. Carral from Spain. He has a museum in Spain. I don't know how many doctors have a specific museum dedicated to them all over the world. He was an artist as well. This is him designing neurons. He had a huge impact in the understanding of the brain histology. So from his era, back in the late 19th century, today we have a lot of modern equipment to say the way we observe cells and how cells behave with each other at the tissue level and sub-tissue level. Why histology? A lot of students in medical schools totally hate histology. I will be honest, you will hate it as well. Most of the people just see pink, less pink, more red, more purple things under the microscope. They are not able to recognize it. It is difficult to recognize the different cells, the different tissues. It's a hard discipline because it takes time to accommodate your eye with the microscope to be able to identify the differences, but it's worth it. Why it's worth it? Because it can help you go from the clinical question to the tissue mechanism. And it really helped me because I was not very, it was not easy for me to study histology as well as a student. And growing up and becoming more and more familiar, I realized that it is absolutely essential to the clinician to understand how the cells work at the tissue level. And now, if these observations, the first ones on the tissue level, the others that we have indirectly, as Professor Vetsika just mentioned, at the molecular level, they can help us find new solutions about old problems that we still cannot successfully manage. So this is my professor in my PhD thesis, and still collaborate, and this is my first project I'm going to talk about. My PhD was about these zombie cells. I started back in 2010. Back in 2010, we could only observe the zombie cells in cell cultures. That was a problem because we knew these cells, the senescent cells that are now recognized, this is the 2022 version of the hallmarks cancer. We discussed about it 2 weeks ago, I think. And senescent cells are now recognized as part of the biology of cancer. But back in 2010, we only had this observation on a culture level. Why? Because the only biomarker that we had was an enzymatic activity. And enzymatic activity could only be observed in cultures of frozen tissue, not in paraffin embedded sections. These are the sections we all have in the lab. When you do a biopsy, you take the tissue, you put it in formalin, and then we store it on paraffin tubes. It was impossible to detect senescent cells in these tissues. We knew they were there, but we could not prove it. So Professor Willis had a very nice idea back then. Let's try to do something very simple. To use an old technique, we use this technique, Sudan black bee. It was a forgotten histochemical technique. They use it for lipids. And we use it in the lab very rarely nowadays because it has a major drawback. It is ethanol diluted. And it's not easy to use. So we did a series of experiments. We used mice from a friend in Spain, Professor Serrano. We used cells from a friend in Athens, Professor Kletsas, irradiated cells. And we checked all the systems and we saw that Sudan black can stain this pigment called lipofuscin, which aggregates inside the senescent cells. The zombie cells are full of this stain, this pigment, and we managed to stain it. And it was a good work because when we published, and we showed, yes, you can see it on paraffin-embedded tissue. It's not easy, but you can do it. They liked it that much that they put a research on the cover of the journal of that issue. And then 10 years later, with the help of other friends from chemistry, from pharmaceutical chemistry, from the Polytechnic University, they managed to develop what Professor Vetsika just mentioned, a biomarker that can control live cells, living cells, and can detect immunosenescence. Professor Vetsika mentioned immunosurveillance. When you have cancer, this doesn't work well because some of the cells in the blood are zombie cells. Okay, so we managed to detect this one. Now, I forgot. Here we are. Another project I am involved in is with Professor Skarlis from the School of Pharmacy at ECPA. So why I work with him? A few years ago, he was contacted by a person and told him that this berry here, which is called in Latin Diascorea communis, is able to stop gingivitis. So they knew it in the village, they had it in their area. So he decided to see if we can use it for the treatment of gingivitis. How can you prove that it is effective? First of all, you cannot start experimenting on people, so you have to do it on animal models. First, you try on cellular models, then you try on animal models. The problem with animal models is, now here we have mice, they don't develop caries and they don't develop gingivitis easily. They are not like us, that we sweep and then we have tooth decay. They don't get easily tooth decay or gingivitis. So we had to do a model. Imagine that we put dental floss on the teeth of the mice to keep their food and create artificial conditions of gingivitis and dental caries. And we established this model. It was actually Professor Rally's idea, and with a lot of help with the students, they managed to keep the mice from removing this device from their teeth. And we did so, yes, that it is effective, but also, that's why we needed the histology. It's not toxic. It's very important of what you use. Not only is beneficial, but it's not toxic as well. It doesn't kill normal cells. You have to use of the lane in the blood from the Hippocrates. First, do not harm. So the first thing you have to check is that it doesn't cause toxicity. There comes histology again. So an ongoing project that we have now, if you want to participate, is about oral mucositis. Oral mucositis is a side effect of chemotherapy. It has to do with inflammation, toxicity, and microbial disruption on the mouth of patients who take cytotoxic, mainly cytotoxic chemotherapy. But it happens to some people who are on targeted therapies, and it may be so severe that it can make them stop the treatment. And we think that this gel that we have developed could be applied in this patient. Why? Because it is non-toxic, because it is microbiome friendly, and it can help both alleviate and probably prevent the mucositis development. So if you're interested in animal studies, if you're interested in making some reviews on toxicity in microbiome, more than welcome to join this project. Another ongoing project is with Professor Evangelia Pavlidou, International Technical Metrology, and Nefeli Laobat from the Medical Biology Network. What we do with this group, we had developed a nice nanomaterial which has anti-cancer properties. That was back in 2019. Recently, we had an interesting idea together with a biomedicine company, let's say, that creates custom-made dental implants to put this as a coating on custom-made dental implants so we can offer long-term anti-inflammatory and probably anti-cancer treatment or effects in a constant device that is in the mouth of the patient, especially useful for patients who have undergone oral cancer and they use specialized implants to replace bone loss in the jaw of the jaws. And these are 3D printed. We're going to check them in cell culture. Hopefully, we will get, let's pray, we look for a grant for this project. So if any of you is interested in 3D printing, solutions of 3D printing in medical, we can do a nice review there. And Mr. Agelis, who has the company, would be more than happy to help you and give you all the data, how they do the 3D printing. And if you're interested in nanomaterial, again, be my guest, please, to write reviews. I would be more than happy to collaborate with you. Another ongoing project is in collaboration with the university in India. I needed India in this project. Why? Because we don't have this disease in trees. This disease is the most common precancerous condition in the world. It's called oral submucous fibrosis. It affects millions of people in India and Southeast Asia because of the habit to chew this areca nut mixed with tobacco. Why they do that? They work 16, 18 hours a day. This chewing habit acts like a stimulant. It helps them work more, keep them active. So as they chew this, they develop fibrosis of the mouth. They cannot open their mouth enough. And on these sides, they develop cancer, even at very young ages. And even if they use this tobacco mix for very little time, for a few years. So it is actually a form of carcinogenesis in people. I was like that Professor Akin from India, I cannot pronounce his name so many years after we collaborate, wanted to send and trust us with some of his samples and his expertise. And we are currently checking for senescence biomarkers on the tissues because what we believe and that we are about to prove is that the cellular senescence of the cells caused by the damage of the tobacco, it drives the fibrotic process because senescent cells produce inflammation. And from this case here, that was from Professor Skarlis archive, unfortunately this patient died, we showed something that we suspected as well, but we didn't have enough information to prove it, that this P16 marker, again a biomarker, which is a surrogate marker. Surrogate means we use it instead of the normal marker for HPV infection. When you find P16 in a tumor, you assume the tumor is positive for the HPV virus. That's not always true. And here we saw that this P16 positivity may be related to senescence and not always to HPV infection, because this particular patient was positive for P16, but negative for the identification of the HPV virus. So why did I place this case here? Because some of you may not want to be part of the review process, of the review paper. You may want to participate in a case presentation. Case reports don't easily get published, but can be presented in conferences. This is a nice start as well. If you don't feel ready to participate in a review project, you can contact us to find some clinical cases to present. You are familiar with the process because we do it every week. We present a case, we discuss it. And I have tried to grab this were presented online international conferences, first year, second year students, undergraduate students like you. So be our guest to participate in this process as well. To put the connection with the next subject, which is embryology, another boring subject. So I have here a story from the recent past. 60 years ago, in some congresses around the world, clinicians started to report children with limb abnormalities, born with limb abnormalities. One of them was in Germany, the other was in Australia. They started to put in order these cases to present with very good documentation, all the clinical facts, all the laboratory exams they had at the time, and gathering stone by stone all this information, they managed to bring into the light a major problem of the mid-20th century, the teratogenicity effect of a drug called thalidomide, which was prescribed to pregnant women. And this has caused the whole generation of people who were born with limb abnormalities. They didn't know the mechanism back then. Embryology, people like Professor Sfontouris, who's going to talk next, developed next the theory that the anti-angiogenic effect of thalidomide doesn't allow the limbs to develop normally during pregnancy. And now thalidomide is no longer used in pregnancy. It is used for very specific immune diseases under strict regulation. So what I wanted to say is that from one simple case report, well documented, you can have important information. So don't be snobbish on case reports. If you want to start with that, it can really help you. So as you probably have understood, medicine is a team sport. Nothing happens from a single person. We work in teams. So far, I have been very lucky to be part of many teams, clinical teams, educational teams, research teams. Now I'm part of UNIC Athens team. You are part of UNIC Athens team, and I hope that we will all collaborate not only on the educational level, but also at the research level. Thank you very much.
Έχεις κακή, δεν το έχεις στείλει.
Θα στείλει, δεν ξέρω αν έχει προλάβει να το ενημερώσει.
Όχι, δεν το βλέπω. Έχεις δίκιο.
Good evening. Thank you all for being here. I kind of skipped the queue, jumped in front of Professor Kararigas while I wanted to catch you while you're still awake. So I'm going to talk to you about what I'm working on, both clinically and in terms of research. My name is Ioannis Sfontouris. I'm a clinical associate professor of embryology. I'm the lab director at the IVF unit of Ioannis. You haven't seen me yet because we will start our lessons in the second semester, so I will be seeing more of you in a month or so. So I'm going to talk to you about research in embryology and reproduction. So, what we are doing in as part of an IVF cycle is summarized in this graph. Okay, so these are the main stages of an in vitro fertilization cycle. So the cycle starts with ovarian stimulation, which means that we administer a hormonal regime to the female patient in order for her to start producing multiple follicles. You know that in a natural cycle, the woman produces one follicle, one oocyte. So we want to what we want to do is stimulate the production of many follicles. So for this reason, we administer drugs. So when the ovarian stimulation is complete and we are happy and we have all the follicles developed and the oocytes are ready to be collected, we move on to the egg retrieval stage, which is here. Okay, so now the patient comes into the clinic, she goes into the theater, and the gynecologist performs an ultrasound-guided oocyte retrieval and aspirates all the follicles, and then we get the eggs. Okay, so all the follicular fluids are passed on to the embryology laboratory. The embryologists look at the follicular aspirates down the microscope, we identify the oocytes, and then we separate them in special culture media for fertilization. At the same time, on the same day of oocyte retrieval, we also retrieve the sperm from the male partner, and then what we do is we fertilize the oocytes with the partner's sperm. The next day, we check for signs of fertilization, and then the start of the embryo culture. So then we place the embryos in special incubators with special culture media, and the embryos start developing. Okay, and at the end, what we do with the developing embryos, we will either transfer them back to the patient, or we are going to cryopreserve some of them or all of them, or we are going to perform pre-implantation genetic testing, which is testing the embryos before we actually implant them, checking for chromosomal abnormalities, either numerical, which is aneuploidies, or structural abnormalities, or for monogenic diseases like beta thalassemia or cystic fibrosis. Okay, and then after 10 to 15 days, the patient performs the pregnancy test. So if she has a positive ACG value, means that she's pregnant. So this window, okay, spans a few days. So usually the ovarian stimulation phase takes about a couple of weeks, and then the laboratory phase from oocyte retrieval to embryo transfer takes maximum 5 to 6 days. So it is, although it might seem a bit simplistic, it is a very exciting field, IVF, because it combines many different scientific disciplines. So we are using all these disciplines, endocrinology, physiology, and physiology is my favorite because I have a PhD in reproductive physiology. We also use anatomy, pharmacology for the ovarian stimulation, biochemistry for the interaction with the culture media, cell biology, obviously, cell biology. The oocyte is the largest cell of the human body, as opposed to the spermatozoon, which is the smallest one. Okay. We use genetics and molecular biology for the pre-implantation genetic testing. And also, IVF is a medical field that has incorporated a lot of modern equipment. So we have a lot of toys to play with. We have fancy incubators, time-lapse, artificial intelligence. So it is a sector that is rapidly evolving, and always there's new equipment that is becoming available in the market. So I'm going to just summarize my research interest. So first of all, a part of my research and the published papers was on ovarian stimulation. So that is relevant to obviously endocrinology and physiology. A very big chapter in IVF is ovarian stimulation protocols. So ovarian stimulation protocols combine hormones and generates analogs in order to control the cycle of the woman and administer exogenous gonadotrophins in order to have a controlled way of follicle development. Okay, so we have done some work on the optimization of iron stimulation protocols, especially in terms of the best generate analog, either the generate agonists or antagonists, to optimize the stimulation. And we have particularly looked at the comparison between agonists and antagonists in special subgroups of IVF patients, which are the most difficult ones, let's say. So it's patients with PCOS. And so these are the patients that produce large numbers of oocytes, who have many follicles, we have many oocytes retrieved. And on the other side of the spectrum, we have patients with low ovarian reserve. They're difficult to stimulate. They do not respond very well to the stimulation. And usually we get a very small number of oocytes at the oocyte retrieval. At the same time, especially for PCOS patients, when you stimulate the ovary with gonadotrophins, what you might end up with is an exaggerated response of the ovary. So what you might end up with is an iatrogenic complication called ovarian hyperstimulation syndrome. So ovarian hyperstimulation syndrome is a complication of IVF. So we have done a lot of work in predicting, but mainly in preventing and the management of ovarian stimulation syndrome. We know now that modern protocols, if you trigger the final stages of oocyte maturation with generation antagonists rather than ACG, then you virtually eliminate the possibility of OHSS. But even if you get OHSS, then we found that administration of generate antagonists again is able to dramatically reduce the syndrome. And in this way, we are able to manage the patient also in an outpatient basis, because usually if you get severe OHSS, the woman has to be hospitalized. She has to be administered intravenous albumin and electrolytes. And sometimes because there is fluid accumulation in the peritoneum, she might need to have fluid aspiration, because the way OHSS works, so this is pathophysiology. When you trigger the final, so the last injection that women have before oocyte retrieval is ACG. So ACG mimics the action of LH, but what also ACG does is it stimulates the production of VEGF from the ovary. So we know that VEGF is an angiogenic factor, okay? So what VEGF does, it increases the vascular permeability. So by increased vascular permeability, you have shift of fluid from the blood, okay, into the third space, and you end up with ascites in your tummy, okay? So this is also associated with hemoconcentration, okay? So there are lots of complications. So this has been a chapter of our work that has really, provided some evidence and some ways to manage OHSS. Fertilization. Now into the more laboratory parts of IVF. We know now, and especially using time-lapse technology, and I'm going to show you a video of a time-lapse video of embryo development. We know that the first cycle, which means the period until the first cleavage, the first division of the fertilized oocyte, hides a lot of information, okay, a lot of information that can serve as biomarkers, as you say, for embryo quality, and can predict subsequent implantation and embryonic development post-implantation, okay? So we know now that fertilization and the biological events that occur during fertilization are very important. And it is only recently that we have come to identify and study these events. So we have, you can see here from the fertilized oocyte up until the first cleavage, we have several different features like the polar body emission, the appearance and juxtaposition of prenuclei, the female and male morphology of the prenuclei, cytoplasmic halos. So, and the intervals and the timings that these particular events take place are also very important. So we know that these features here can be analyzed, studied, and be used as predictive factors of future embryo development and pregnancy. In addition, fertilization, of course, is very technical in IVF. So we use mainly two techniques. We either use conventional IVF, okay, which is mainly placing the oocyte together with spermatozoa inside a culture dish with medium, okay, leave it overnight, and then the spermatozoa swim and fertilize the egg. However, in cases of poor sperm quality, what we do is we use another technique called intracytoplasmic sperm injection, ICSI. So this is ICSI. So what we do is we pick up a single spermatozoon inside an injection pipette, then we pierce the oocyte and we deposit the spermatozoon directly inside the egg, okay? And this is the way that we can fertilize the oocytes. So again, there are many factors that are implicated in this technique, the timings, the techniques, and also difficult cases like failed fertilization that require additional exogenous administration of calcium ionophores, which is artificial oocyte activation. Again, we have shown that AOA can be used, and we have published a nice systematic review in human reproduction showing the exact indications and the results of using this technique. However, the main focus now and the main exciting areas has to do with embryo development. So embryos are very important. They are very sensitive. They have specific requirements and specific needs while they are inside the lab. So while they are in our hands, we have to really be very meticulous and very particular in the way that we handle and we culture embryos. So part of my research has to do with embryo culture systems. So the best way to culture embryos, different types of culture media, single versus sequential, in order to maximize the production of viable embryos, and of course, in the end, to increase the chances of a patient having a baby, because in IVF, the final outcome is the birth of a healthy baby. Okay, so everything we do, even clinically or in terms of research, the main outcome is always live birth. And also, apart from live birth, what we also monitor is obstetric outcomes and perinatal outcomes, the health of babies, the incidence of congenital abnormalities. So all that are very important outcomes, and this is what we are trying to optimize. Another very important area, and it's and I think it ties very well with the research that Professor Vetsika is doing, is the non-invasive embryo assessment. So what we do in the lab, we culture embryos inside a dish with culture medium. So we want to develop ways to evaluate embryos. So the main way to assess an embryo is look at it down the microscope and see, how many cells it has and if it looks nice or less nice. Okay, but morphology is not always the best way to go. So what people are doing, and it's a very developing field in IVF as well as other fields in healthcare, is non-invasive evaluation. So we use the culture medium that the embryo has developed in order to measure several things. So we can measure metabolites, we can measure the proteome, we can do transcriptomics, we can do a combination with multi-omics, okay? You can even measure cell-free DNA inside the culture medium. So also this has been another chapter that I have been involved in. And also, what we are doing, because we use it clinically as well, we have a research interest in the use of artificial intelligence. So artificial intelligence can also be used as another automated, non-invasive way to assess the embryos, and it can give us information and as a predictor for implantation, for birth, and even for the presence of aneuploidies, which is chromosomal abnormalities in the embryos. I believe that this week you are doing what you are being taught is chromosomal abnormalities in embryos and syndromes, Down syndrome, and all that. So it all starts here. Okay, so this might be, I'm going to show you. The first 6 days of development. So this is the pre-implantation embryo development. Okay. So what we can do is we can culture the embryos up until the blastocyst stage. The rest of the 9 months is post-implantation development. Okay. But it all starts here. So the meiotic non-disjunction can happen here. Okay. Effects from exogenous toxic substances can interfere here, and we end up with teratogenesis, for example, or with abortions and miscarriages. So these days of pre-implantation embryo development are very important and very sensitive as well. Okay, so the pre-implantation embryo development starts with the unfertilized oocytes. Then on day 1, we have the observance of the pronuclei, which means that the oocyte has been fertilized, and then the mitotic divisions start. So we have the first division at the end of day 1, then on day 2, we usually have an embryo with 4 cells. On day 3, after fertilization, we have 8 cells. On day 4, we have the formation of the morula. On day 5, we have the formation of the blastocyst. Now, the blastocyst is a very crucial stage because at this stage we have the first differentiation of the 2 cell layers. So we have the inner cell mass, which is this blob of cells right here, which is going to give rise to the embryo. And these cells around the blastocyst, the trophectoderm cells, are going to give rise to the placenta. So already from day 5, we have the first differentiation of the cells. Okay? And we are able to keep the embryos in culture up until the blastocyst stage. So in order for the embryo to keep developing, it has to be transferred to the uterus, it has to implant, and only then it is able to continue developing. So a very cool toy, like I said, but also a very useful tool has been the use of time-lapse technology. So before time-lapse, what we used to do is have, who said it, Professor Georgakopoulou, snapshot evaluations. Professor Vetsika. So a snapshot evaluation is what? So you have the embryo culture developing inside your incubator, you have no idea what's happening. You take it out of the incubator, you put it under the microscope for 10 seconds, you look at it, you see it's a 4-cell embryo, you put it back in the incubator, and that's it. You have no idea what happened before or what's happening after those 10 seconds that you observe. So now with time-lapse technology, we have special incubators that have integrated cameras, and they can monitor how the embryo develops 24/7. And I'm going to show you this video here. So you can see from the unfertilized oocytes, the appearance of pronuclei, the embryo begins to divide. You have 4 cells, 8 cells on day 3. You can see that the cells will start to compact, forming the morula, and then a small cavity will start forming, and then we have an expanding blastocyst. So what you saw now are the first 5 days of embryo development. So using this tool, not only we see nice videos, okay, and not only are we able to assess embryos better, because now if we have, for example, 10 embryos for the same patient, we can use more objective criteria in order to identify which embryo is the best to transfer. Okay, this is very important because what we want to do is IVF here is also not only increase the pregnancy rate, but also reduce the time to pregnancy. You want a patient to become pregnant as soon as possible, ideally with the first transfer. Okay, so apart from that, what time-lapse offers is what we call big data. We have a multiple of data in terms of intervals, in terms of cleavage timings, okay, embryo morphology grades, and that is ideal and goes hand in hand with artificial intelligence. So this is where AI comes in. So AI can use this data, the image data, so it can analyze the images. It can also analyze the timings, okay, and it can offer us a new way to assess the embryos and make a predictive assessment for each embryo regarding each embryo's potential to give us a pregnancy, and also the potential that each embryo has to be euploid or unploid. Okay? So what we use is mainly convolutional neural networks, deep learning, to train systems to identify hidden features inside the embryo that the human eye cannot see, okay, in order to help the embryologist make more informed decisions in terms of selecting and managing the embryos of a patient. Okay, you can see here photographs of a blastocyst, how they look under light microscopy. So this is the inner cell mass and the trophectoderm, and you can see these special features that the AI might be able to see and correlate these features with specific outcomes. So this is another area that we are working on. We have used artificial intelligence, and we have some very nice data showing that AI can be a very good predictor for chromosomal abnormalities. So just by looking at the blastocyst, the AI can tell you if this blastocyst is more likely to be euploid or aneuploid, okay? And in this way, we have a non-invasive assessment. Because the invasive way to analyze the genetics of an embryo is to do an invasive procedure called biopsy. And we do this under the PGT, the pre-implantation genetic testing. So what you will have to do otherwise is use a laser, cut a piece from the trophectoderm of the blastocyst, send it for genetic analysis, okay? So this is highly invasive. Of course, it's diagnostic and it's more reliable, but the AI can also give you an indication and also help you to rank embryos, which comes first, second, third, and so on, in terms of viability and potential to implant. What we are currently doing, and I'm very happy to collaborate with our friend Thanos Anagnostopoulos on this, we are editing a special issue in the journals Frontiers in Reproductive Medicine with the theme non-invasive approaches for the assessment of human pre-implantation embryos. So this is ongoing and it is open to submissions. So it's a very broad field, non-invasive assessment that includes all the omics. It includes time-lapse, it includes artificial intelligence, and it's very exciting because there's a lot of interest, and it can bring together different disciplines under the same theme of the assessment of human pre-implantation embryos. Another area that I have been active on is participation in working groups for developing guidelines. For many years, I have been a member and a board member of the European Society of Human Reproduction and Embryology, ESHRE, which is the largest scientific society for reproductive medicine globally. So, and also for 3 years, I was chairing the embryology group of ESHRE. So, as part of that, I have been involved in the development and writing of several guidelines and recommendation papers specific to laboratory embryology, and they have to do with the evaluation of oocytes and embryos, for example, managing chromosomal mosaicism, use of time lapse, the use of add-ons, which are extra treatments, secondary treatments in reproductive medicine, pre-implantation genetic testing, and currently I am chairing the working group that is going to publish the revised guidelines for good laboratory practice in IVF laboratories. And finally, and this is my last slide, I'm also involved, I'm a member of the Council of Europe, and in particularly the ETQM, the European Directorate for the Quality of Medicines and Healthcare. I am a member of the working group that is writing the 6th edition of the guide for cells and tissues. So this is going to be the new version of the European Guide for the quality and safety of tissues and cells. So that includes the entire spectrum of human tissues and cells, and myself and other colleagues participate as experts in human reproduction and embryology. So this is also work that is ongoing. I believe that the 6th edition is going to be published sometime in 2016. And that was it. Thank you very much for your attention. These are my details if you want to look me up and contact me. Thank you very much. Yours.
Γιατί δεν άλλαζε ο Γιάννης της μάλιστα.
Έλα.
Γιατί δεν άλλαζε.
Τα άλλαζε. Από πώς τα άλλαζε.
So raise your left hand if you're still awake. Okay. So hopefully everyone is awake. And you can hear me okay? Is this microphone close for something? Okay. So now you know why Dr. Sfontouris will be with us at the plenary this Friday. And now you also know why Dr. Sfontouris will teach you reproductive physiology and not myself. Right? I just decided this. Okay. So we will go into my topic basically with an overall title I have come up with for today: sex bias, mechanisms of stress-induced cardiovascular remodeling. I will not bore you with my personal trajectory. I will just go directly into the topic. I understand that it's been a long day, and I believe it's just a third of you still here, so thank you for sticking around. Let's see if it really works. No, I don't think it works. Okay, now it works. Okay, so This is one of the very few occasions that I can use the unequal symbol, unequal sign, sorry, between the male and female symbol and get away with this. Why is this the case? This is due to the fact that there are major sex differences in terms of disease prevalence. So what I am showing you here, basically, and this will build up in the middle, it's true for many different diseases, but I am studying cardiovascular diseases. So in terms of prevalence, when we think about coronary heart disease, basically, this is, as you can see here, it's mostly a disease of men. Of course, there are several exceptions, and we're talking about an occlusive type of coronary heart disease in this case, because women suffer from other type that we will discuss later on in your studies. There are also major differences between the sexes in terms of risk factors. So you're not supposed to be able to read this, so no worries. So if we consider current smoking or former smoking, this is a more relevant risk factor for men than women. So men are represented with a darker color in this graph. But if we think about hypertension or diabetes, these are more relevant risk factors for women than men. Okay. There are also major differences between male and female individuals in terms of presentation. So when we think of, again, in a simplified manner, of heart attack, we will discuss later in your studies again the details. Men tend to present more often with the typical symptoms, so chest pain, for example, while women tend to present with more often with atypical symptoms, so shoulder pain, or what is usually misunderstood as digestive problems or panic attacks, and they are sent home and they eventually develop either major complications or eventually even die because they have been misdiagnosed. In terms of pathophysiology, so speaking to the ischemic type of heart disease, men present more frequently with localized stenosis in their vessel, while women have a wider thickening of the vessel wall. What is important for you to keep in mind is that for this situation, we have established guidelines for diagnosis and treatment. For this situation, we don't. So again, a lot of women, a lot of female patients are not treated properly. So this is a major issue. In terms of therapy and treatment, so these are two different notions. I don't want to confuse you too much today, but if we think about a specific medication for heart failure, which again, I'm not going into details, maybe you can tell by the graph. So we have women placebo here. So women were not taking the drug, the drug, and women taking the drug basically, they presented with a higher mortality. So in other words, and being very blunt, this drug was killing some of the female patients. This was not, of course, the case for the male patients. And then in terms of prognosis, the outcome, and the absolute mortality, if we look at patients with heart failure, there is a higher proportion of male patients with increased mortality compared with female patients. Again, nothing is black and white. When we have, for example, the case of diabetes that we said is a more relevant risk factor for women, then this picture is exactly the opposite. So women present with higher mortality than men. Okay. Before I continue, I have already talked to group 4 about this and maybe once in the whole group, but again, I don't know who's been present or not. Just to take a moment to go through sex and gender, two terms that are interchangeably used, but not always accurately used. So when we discuss sex differences, we're looking at biological aspects. I have also a schematic representation on the following slide, while gender is all about psychosocial and behavioral aspects. So if we think of sex, then we're looking at sex chromosomes that we have been studying last and this week. We're looking about sex hormones and so on. When we consider gender, then this is more like sociocultural aspects and stereotypes. Like, for example, once upon a time, the man used to be the breadwinner. So I hope this is clear and you will be able to distinguish between sex and gender. Now, the problem is that many of these sex differences, we're considering sex differences on this occasion today in pathophysiology are poorly understood. This means that we don't know the underlying mechanisms. We don't have any sex-specific or sex-biased therapies. This is also different if it's sex-specific or sex-biased. So many men and women do not receive appropriate medical care. The solution is to start by characterizing the sex differences with the attempt to elucidate the underlying mechanisms, and hopefully this will lead to the identification of novel sex-specific therapeutic targets, and this will bring us a step closer towards personalized healthcare. Okay, back in the lab, the overall hypothesis that we are testing is that sex, biological sex, and particularly the sex hormone 17-beta estradiol or estrogen. So this is the abbreviation for 17-beta estradiol, the main estrogen form, and estrogen receptor. They regulate several biological processes, including mitochondrial function that we discussed a little bit today, calcium handling, the development of fibrosis, and cell death. I'm showing you here apoptosis in particular. And the main aims include to characterize the sex differences in the context of myocardial hypertrophy in particular and heart failure, and to elucidate the underlying mechanisms with the expectation of identifying novel therapeutic targets. Okay, I will just show you just one project only a few years ago that we performed. And I will keep things very simple, not getting into too much detail. So we were looking at aortic stenosis patients, so patients that suffer from aortic valve stenosis, and they develop a number of complications, particularly left ventricular hypertrophy. We have touched a little bit upon hypertrophy as well. And we came up with a maladaptive remodeling index, which includes basically some cardiac structural parameters being modified. I'm not going into details here, just say, keep in mind that the maladaptive remodeling index is something showing a negative prognosis, basically. So we found that a higher proportion of the male patients with the disease we were studying with aortic stenosis had this maladaptive remodeling index compared with the female patients with the same disease. In order for us to identify the underlying mechanism, what we did, we collected little pieces of their hearts. I want you to keep in mind that these are patients who are undergoing surgery and they need to come out of the surgery room with their hearts functioning. Yeah, so they were willing to donate for our research purposes a little piece of their heart, literally, yeah. And we performed a genome-wide expression profiling to be able to identify gene regulation at the transcriptional level on a whole genome level. We found that a number of genes were male or female dependent, but there was also a number of genes that was commonly regulated. These are numbers. We want to understand biology behind numbers. What we found was that many of these genes belong to pathways that are related to fibrosis. Fibrosis is something detrimental to the heart, basically. But again, not going into too many details now. On the other hand, the female hearts, we found a number of genes that are related to inflammatory pathways, but guess what? They were down-regulated. There was a repression, basically, of these inflammatory pathways. So what we see here, this sex bias picture, so higher proportion of male patients with this maladaptive remodeling index than the female patients, we believe that this is a molecular signature, basically, underlying this effect. So pro-fibrotic pathways are increased in the male heart, while a repression of inflammatory pathways takes place in the female heart. Okay, so the main take-home message for you, as I promised you, I will keep things short and simple, is that there are important sex differences, basically stemming from the sex hormones and sex chromosomes throughout development and the lifespan. And this lead to sex and gender differences that I have not touched upon today at all. And in order for us to move away from this situation, which is the one drug fits all approach, which we know that does not work, we need to take this into consideration so that we can come closer to this situation, which is a step towards personalized healthcare. So that was it from my side. Thank you for your attention. And Dr. Gaitanaro has just arrived, so she can maybe modify. Sure. There was a question from Krista to Dr. Vetsika, I remember.
Yes,
Maybe the rest of the faculty can join me also here for any questions.
yes,
It's about intracellular vesicles.
yes.
And you told that they can pass the blood-brain barrier, but we were taught that neurotransmitters mostly do that. But the question is that those vesicles contain chromosomes that or are chemicals.
No, they're not chemicals. No. These vesicles, as I said, they contain all the information that from the cells that are coming from. So by that, they can contain proteins, DNA, RNA, microRNAs, everything that a cell has.
Chromosomes copy.
Not like as a chromosome, the whole, but part of that genes. Okay, so they can transfer. So if that goes to another cells, so that genes can you. So that means that gene that DNA can move into a cell, and that can be transcribed and translate to a protein if that's the case.
I can add to that just to keep the conversation going. There are these small extracellular vesicles are also secreted by embryos.
It depends. Okay, that's a big debate now because that's more extracellular vesicles and it has started as like exosomes. Some of the people they know that by that name. But the thing is that some people they've been confused. Now exosome doesn't exist as a term because now they have identified three different by size. They have three different type of exosomes of small exosomes last year. Okay? So now all of these they call them small extracellular vesicles. Okay, but of course, because that's what I say, every cell can release those, and you can get a lot of information out of this. And yes, cells, like yes, embryos, they do that. They do secrete that. But another thing is like some of the people they've been confused by ectosomes. Exosome is being released. It's how they develop. Okay, how they develop. You have a cell, yes? And then at some point you have internalization of the membrane of the cells. So they develop a globe. And that close and makes a small one, and that transfers inside into the cells. And again, there is a second realization of the membrane of the small exosome. So that means they take all the information from inside the cells. And at some point, these small vesicles, they've been excreted from the cells. They just further out. But there is another one that called it ectosomes, and that's a confusion. It's like versions like that, but then you develop a blob like this. It's not like it's being secreted. Develops a blob close, and they say, old days, they say this is an exosome. That's not the case. But you have to have in mind that all cells, every cell that we have in our body, they do produce that, and they send that out to do what they're supposed to do. And they're in every fluid that we have in our body, or in cell culture. Like if you do have cells and you put them in cell cultures, then in the medium you can find these exosomes. Yes, and you can take that, you can isolate, and then you can see all the information that you need from the cells, because these are the ones that can send the information of the cells everywhere in the body. Is that okay?
Do we have any other question? I was wondering, it's very quick.
Yes,
Sorry about that. So I was wondering, which artificial intelligence tools are you using, particularly, especially with respect to big data? Because I know that ethics has been lately involved in the mix, and they are trying to have ethicists on board. So I only know one artificial intelligence platform that uses ethicists, but I was wondering which ones do you use in your practice?
There are some commercially available AI tools. One of them is called IDAS4. This is the one that we are primarily using. And but the way we use it is strictly on as a support tool. So we do not have AI tools in the lab making their own decisions.
Don't code.
No. We do not code. It's very simple. What we do is the AI looks at the image of the blastocyst or the video of the blastocyst, and then it gives you a score depending on how likely the embryo is to give you implantation or not. And that's it. So sometimes we use it as a second opinion. If we go to distinguish between two or three embryos that we cannot make ourselves up as embryology. And this is really how but we have also used it for research, okay? And we have used it to predict, we see that it can also have a good association with the presence of aneuploidies in the embryos, because it seems that embryos with chromosomal abnormalities have different cleavage patterns, and we know that they develop slightly more slowly than the euploid embryo. So this is the way that we are able to distinguish, between euploids and aneuploids in a non-invasive way, without any biopsy.
So can you think it uses sample analysis to provide the information that you provide?
Yes. Because we work in a very large hospital group here, they are very strict with patient data and confidentiality and GDPR. So all that is, it comes first before we introduce anything new inside the laboratory or inside the clinic in general that might use patient data.
Yes, it might be trained because it was interesting. I thought this was interesting for the students because normally.
That's why you need to use the microphone, and so that we can be recorded also, both of you, not Dr. Pavlidou only, Dr. Sfontouris as well. Here.
I was just saying that when I did my training.
Yes, this is the recording going on here.
Yes.
No.
No, I was only trying to make a comment about when I had my training on artificial intelligence, and they told us that we train the machines essentially. So we did that strictly under licenses, the information that we provided. That's why I asked you, because most of the times you think that this is open access, information is out there on AI, but it's
No, we do not.
So you see, this is why I asked the faculty to join me here.
So we are not training any new models. We are buying already, developed AI tools. Okay, so it is not, as sensitive as you say. Okay.
So